Good afternoon. Thank you for giving me the opportunity to be here today. My name is Quynh Wang. My background, I'm a board-certified adult and gerontology nurse practitioner. And my practice, I work with the Arkansas Heart Hospital Clinic, endocrinology, and diabetes. I work with Dr. Irina Lindell, Dr. Beth Crowder, and an amazing team of interprofessional team of healthcare providers to provide optimal care of diabetes for patients in need. I'm here today to talk about SGLT2 inhibitor, one of the diabetic medication that actually my most favorite medication right now for diabetes. It's not even 100 years in the invention of insulin. And now we have more than 12 different therapeutic drug classes to treat diabetes. We have phenomenal technology. However, we still see a large number of people with diabetes. More than half of people with diabetes are not controlled. The A1C is not less than 7.0%. And many people are probably walk around with diabetes and not even know it. 80% of the entire societal cost for diabetes is related to long-term complication, hospitalization, revascularization procedure, and dialysis. And there's no such thing, it's just diabetes alone. Diabetes comes with macrovascular complication and microvascular complication. Most patients with type 2 diabetes usually have postprandial glucose elevate first. After the pancreas working so hard 24/7 for several years, the beta cell function decrease. That's when we start to see fasting glucose go up. That's why in the cascade of events, you usually see the macrovascular complication first, like patient with heart attack, stroke, and then you see patient with microvascular complication. The mechanism of action of SGLT2 inhibitor, SGLT2 receptor is responsible for 90% of the glucose reabsorption in the proximal tubule in the kidney. SGLT2 inhibitor, as the name suggests, is inhibit the kidney function of reabsorb the glucose, decrease the plasma glucose by excrete more glucose in the urine. Theory is, if the patient is hyperfiltrate glucose, they hyper-reclaiming glucose. And many times they're also hyper-reclaiming sodium. SGLT2 act as a diuretic is still controversial and is not the main mechanism of action yet. However, it does act for some benefit. In diabetic patients, cardiovascular component is huge. We're getting large and fluffy. We eat more. We exercise less. We gain more weight. We get more adipose tissues. We have more stress in life. Diabetes, hypertension, high cholesterol, obesity, all related to cardiovascular disease and heart failure. It is the vicious cycle. Insulin resistance can lead to diabetes. Diabetes increases the risk for heart failure. Heart failure accelerates the risk for diabetes and chronic kidney disease, making diabetes a lot harder to treat. And on this slide, it shows you the diabetes accelerate the time to first cardiovascular event, to the first MI and the first hospitalization of the heart failure. The next slide is show the comorbidity associated with worse prognosis for patients with heart failure. When the patient walks through our door, our mission is to go above and beyond glycemic control for our patient. We want to decrease any complication. We want to give them renal protection. We want to give them protection for their cardiovascular. We have to think, how do we minimize weight gain and maximize weight loss, and how we prevent the hyperglycemia risk for the patient. SGLT2 in the beginning was just assessed in the large trial as the FDA requirement to prove the CV safety for the patient. That's all we hope for. That's all researchers hope for, CV safety. But in the early trial, we just focus on how do we decrease the risk for heart attack with any new diabetic medication. Turns out there's a lot more heart failure occurring. The rate of heart failure is just as high as the rate for heart attack. So we start to focus on how do we decrease the rate for heart failure and how do we decrease the rate of hospitalization for patients with heart failure. There are 3 FDA-approved SGLT2 inhibitors: is canagliflozin or Invokana, dapagliflozin, Farxiga, empagliflozin, or Jardiance. I have all the doses listed on here. It's just 1 tablet per day for the patient. You don't have to up-titrate. It doesn't cause hypoglycemia. And this medication usually decreases hemoglobin A1C somewhere around 0.5 to 1%, and decrease weight around 2 to 5 kilograms. Across all the CV outcome, SGLT2 inhibitor consistently show that hospitalization rate is decreased significantly 30 to 35%. In the CANVAS and CANVAS-R trial in 2017, SGLT2 might hold the key not just to prevent heart failure, but also treating heart failure even for patients without diabetes. In the CREDENCE trial and DAPA-CKD also show that beside the CV outcome, SGLT2 inhibitor can also decrease the risk for renal failure in patients with diabetes and diabetic kidney disease. The CLARE-TIMI-58 trial, DAPA-HF, and APRN also show consistently to decrease the primary outcome of cardiovascular event, cardiovascular death, non-fatal MI, non-fatal stroke. Potential side effect. The potential side effect in this medication is very small. Common side effects are UTI, yeast infections in the patient urinate more sugar, and is good medium of growth for bacteria and yeast infection, but it's usually mild, and it can be treated with a short course of antibiotic or antifungal. The patient with risk for UTI, or every patient, we should educate them really well on proper GU hygiene and how to stay hydrated, make sure they stay hydrated all the time, and side of DKA. Patients with risk for amputation have to be assessed frequently with foot exam. Contraindication for this medication, this one is absolutely not for type 1 diabetic patient. It is not used to treat patients with DKA. It's not recommended for patients with pregnancy and lactation, especially on the 2nd and the 3rd trimester. Not for patients with renal impairment and end-stage renal disease or dialysis. So in 2021 on January, the ADA guidelines still recommend metformin as the first line of treatment for type 2 diabetes patient. What is the next line of treatment? We have several questions to ask. Did the patient have ASCVD risk? Did they have a heart failure, diabetic kidney disease, or established ASCVD risk? If the answer is yes, then the recommendation is to start the patient on SGLT2 or GLP-1. Doesn't matter what the ADA say or what the Endocrine Society say until the ACC guideline in 2020 say that it is safe for patients with heart failure. And among patients with type 2 diabetes, high risk for ASCVD, DKD, and heart failure, it is recommended to start patient on SGLT2. This one is an ideal patient list that I usually go with. I start SGLT2 on my patient with eGFR above 30 anyone with microalbumin above 30, or especially the one with microalbumin above 300, or the patient who are not controlled with oral anti-diabetic agent or insulin. Personally, I see this medication make a huge difference in my patient A1C. Study shows 0.5 to 1, but I see patient make a huge jump to 3-4% in the A1C within 3 months. So SGLT2 inhibitor is a pillar of care for patients with type 2 diabetes and cardiorenal comorbidity. And we as provider should be vigilant in identifying appropriate patients for benefit from additional SGLT2 therapy. Thank you for your dedication to diabetes care, and thank you for your interest this afternoon.